This video is a continuation of the cranial nerve nuclei and the functional component, and this is the third part. Here we'll see the functional components of the seventh cranial nerve, the facial nerve. The functional components are the special visceral efferent fibers. The special visceral efferent fibers arise from the motor nucleus of the facial nerve and supplies the muscles derived from the mesoderm of the second branchial arch or the pharyngeal arch, namely the muscles of the facial expression and etc. Then you have the general visceral efferent. So this is the general visceral efferent fibers. These are the preganglionic parasympathetic fibers to the pterygopalatine and the submandibular ganglion, and these fibers, they arise from the lacrimatory and the superior salivatory nucleus respectively. So these are for lacrimation and the salivation respectively. The preganglionic fibers arising from the lacrimatory nucleus, they terminate in the pterygopalatine ganglion. So this is the pterygopalatine ganglion, from which the postganglionic fibers arise and supplies the lacrimal gland through the zygomatic branch of the trigeminal nerve. The preganglionic fibers arising from the superior salivatory nucleus, they relay in the submandibular ganglion, from which the postganglionic fibers arise and supply the submandibular and the sublingual salivary glands. Then you have the special visceral afferent fibers. So the blue color or the special visceral afferent fibers. So these are concerned with taste sensation. The cell body of these fibers, they lie in the geniculate ganglion, and the peripheral processes of the ganglion cells, they carry the taste sensation from the taste buds of the anterior two-thirds of the tongue except the circumvallate papillae. The central processes of the ganglion carry these sensation to the upper part of the nucleus of the tractus solitarius. The next fibers are the general somatic afferent fibers. They have their cell bodies in the geniculate ganglion. The peripheral processes of these cells, they innervate the part of the skin of the external ear, while the central process terminate in the spinal nucleus of the trigeminal nerve. When you see the clinical correlation, the part of the motor nucleus of the facial nerve supplying the muscles of the lower part of the face, they receive the corticonuclear fibers from the opposite cerebral hemisphere, while the part of the motor nucleus of the facial nerve which supply the muscles of the upper part of the face, that is the frontalis and the orbicularis oculi, they receive the corticonuclear fibers from both cerebral hemisphere. As a result, in supranuclear lesion, that is the lesion involving the upper motor neurons of the facial nerve, the upper half of the face on both sides is spared and the lower half of the face is affected on the opposite side. On the other hand, in the nuclear and the infranuclear lesion, that is the lower motor neuron lesion, the whole face is affected on the side of the lesion, that is ipsilateral lesion. Next we'll see the functional component of the eighth cranial nerve. The eighth cranial nerve or the vestibulocochlear nerve, they consist of two divisions, the cochlear division and the vestibular division. So both these divisions consist of special somatic afferent fibers. The fibers of the cochlear nerve or the central processes of the bipolar neurons of the spiral ganglion. The peripheral processes of these cells, they innervate the organ of corte, that is the hearing receptor in the cochlea of the inner ear. The fibers of the vestibular nerve or the central processes of the bipolar neurons in the vestibular ganglion. The peripheral processes of these neurons, they innervate the vestibular receptors in the semicircular duct for the kinetic balance and in the saccule and the utricle for the static balance of the inner ear. Next we'll see the functional component of the ninth cranial nerve, the glossopharyngeal nerve. The components are the special visceral efferent fibers. They arise from the nucleus ambiguous and they supply only one muscle, the stylopharyngeus muscle, that is the muscle of the third pharyngeal arch. The next component is the general visceral efferent fibers, the dotted red lines, the general visceral efferent fibers. So these fibers, they arise from the inferior salivatory nucleus and they relay in the aortic ganglion, and the postganglionic fibers arising from the ganglion supply the parotid gland via the auriculotemporal nerve, which is a branch of the mandibular nerve. The next fibers are the general visceral afferent fibers. The cell bodies of these fibers, they lie in the superior ganglion of the glossopharyngeal nerve. The peripheral processes of these cells, they carry the general sensation like touch, pain and temperature from the posterior 1/3 of the tongue, pharynx, carotid body and carotid sinus to the ganglion. The central processes carrying these sensations, they terminate into the spinal nucleus of the trigeminal nerve. The fourth component is the special visceral afferent fibers. They have their cell body in the inferior ganglion of the glossopharyngeal nerve. The peripheral processes of these cells, they carry the taste sensation from the posterior 1/3 of the tongue and the circumvalent papillae to the ganglion, and the central processes, they convey these impulses to the nucleus of the tractus solitarius. So when you see the clinical correlation, the lesions of the glossopharyngeal nerve, they produce the loss of gag reflex due to the interruption of the afferent limb. Then loss of general sensation in the pharynx, tonsils, fauces and the posterior 1/3 of the tongue. Then there is a loss of taste sensation from the posterior 1/3 of the tongue. Then you have the hypersensitive carotid sinus syndrome, that is syncope attack. Next we'll see the functional component of the 10th cranial nerve, the vagus nerve. The components are the special visceral efferent fibers. So the unbroken red lines or the special visceral efferent fibers, they arise from the nucleus ambiguous and they supply the muscles of the pharynx and the larynx. The next component is the general visceral efferent fibers. So the red dotted lines represent the general visceral efferent fibers. They arise from the dorsal nucleus of the vagus as the preganglionic parasympathetic fibers, and they supply the heart, lungs, GIT up to the junction of a right 2/3 and the left 1/3 of the transverse colon. These parasympathetic fibers, they supply the viscera through the postganglionic fibers which arise from the small ganglia situated close to or within the walls of the viscera. The third component is the general visceral afferent fibers. The cell bodies of these fibers are located in the inferior ganglion of the vagus nerve, and the peripheral processes of these cells, they carry the sensation from the pharynx, larynx, trachea, esophagus and from the thoracic and the abdominal viscera to the ganglion, from where they are conveyed to the dorsal nucleus of the vagus and also to the nucleus of the tractus solitarius through the central processes. The fourth component is the special visceral afferent fibers. The cell bodies of these fibers, they lie in the inferior ganglion of the vagus nerve, and the peripheral processes of these cells, they carry the taste sensation from the posterior most part of the tongue and the epiglottis to the ganglion, and the central processes, they terminate into the upper part of the nucleus tractus solitarius. The fifth component is the general somatic afferent fibers. The cell bodies of these fibers are located in the superior ganglion of the vagus nerve. The peripheral processes of these neurons, they innervate the skin of the external ear, and the central processes, they terminate into the spinal nucleus of the trigeminal nerve. When you see the clinical correlation, lesions of the vagus nerve produces ipsilateral paralysis of the soft palate, leading to sagging of the palatal arch. The uvula deviate towards the opposite side, that is the healthy side. Then there is a loss of gag reflex due to the interruption of the efferent limb. Then there is a unilateral loss of cough reflex due to anesthesia of the pharynx and the larynx. Then there is hoarseness of voice due to unilateral paralysis of pharyngeal muscles. Next we'll see the functional component of the 11th cranial nerve, the accessory nerve. So the functional components are the special visceral efferent fibers. They form the cranial root of the accessory nerve, and they arise from the nucleus ambiguous, and they are distributed through the vagus nerve to supply all the muscles of the palate except the tensor palatini muscle, which is supplied by the mandibular nerve through the nerve to the medial pterygoid. It supplies all the muscles of the pharynx except the stylopharyngeus muscle, which is supplied by the glossopharyngeal nerve, and it supplies all the muscles of the larynx. The second component is the general somatic efferent fibers. The general somatic efferent fibers, they form the spinal root of the accessory nerve. They arise from the elongated column of cell, that is the spinal nucleus of the accessory nerve, whose cell body lie in the lateral part of the anterior gray column of the upper 5 cervical spinal segments. And these fibers, they supply the trapezius and the sternocleidomastoid muscle. When you see the clinical correlation, the unilateral peripheral lesion of the spinal root, that is the spinal accessory nerve, lead to the paralysis of the sternocleidomastoid and the trapezius muscle. The paralysis of the sternocleidomastoid muscle will result in turning of face towards the same side and the bending of the head to the opposite side due to the unopposed action of the opposite healthy muscle. The paralysis of the trapezius results in the drooping of the shoulder and inability to shrug the shoulder towards the side of the injury. Next we'll see the functional component of the 12th cranial nerve, the hypoglossal nerve. The functional component is the general somatic efferent fibers. They arise from the hypoglossal nucleus and they supply all the intrinsic and the extrinsic muscles of the tongue except the palatoglossus muscle, which is supplied by the cranial root of the accessory nerve via the vagus nerve. When you see the clinical correlation, in the upper motor neuron lesion of the hypoglossal nerve, since the hypoglossal nucleus receives the corticonuclear fibers only from the contralateral hemisphere, the supranuclear lesion causes the weakness of the opposite half of the tongue, and on protrusion the tongue deviates to the side opposite to that of the lesion. Next we'll see the lower motor neuron, that is the nuclear and the infranuclear lesion of the hypoglossal nerve. This results in the paralysis of the ipsilateral half of the tongue, and on protrusion the tongue deviates towards the side of the lesion due to the unopposed action of the genioglossus muscle of the healthy side. Next we'll see the cortical control of the cranial nerve. All the motor nuclei of the cranial nerve are under the control of the cerebral cortex through the corticonuclear fibers. Each nucleus is controlled by both cerebral hemispheres, with the following exception: the part of the hypoglossal nucleus innervating the genioglossus is controlled by the opposite side cerebral cortex only. Then the part of the facial nerve supplying the lower part of the face is controlled by the opposite side cerebral cortex only. The trochlear nerve nucleus is controlled by the cerebral cortex of the same side only. Next we'll see the reflexes mediated by the cranial nerve. So first we'll see the corneal reflex. When the cornea is touched with the cotton wool, the person blinks due to the contraction of the palpebral part of the orbicularis oculi muscle. The afferent limb for this reflex is carried through the ophthalmic division of the trigeminal nerve, and the efferent limb is through the facial nerve. The next reflex we'll see is the conjunctival reflex. When the conjunctiva is touched with the cotton wool, the eye is closed rapidly due to the contraction of the orbicularis oculi muscle. Here also the afferent limb is formed by the ophthalmic nerve and the efferent limb is formed by the facial nerve. The next reflex is the lacrimatory reflex or lacrimation reflex. Irritation of the conjunctiva and the cornea results in the reflex of the lacrimation. The afferent limb is formed by the ophthalmic nerve and the efferent limb is formed by the parasympathetic, that is the facial nerve. Next we'll see about the oculocardiac reflex. The pressure on the eyeball, it slows down the heart rate. The afferent limb is formed by the ophthalmic nerve and the efferent limb is formed by the vagus nerve. The next reflex is the gag reflex. Tickling of the oropharynx either with finger or with a swab stick results in the reflex contraction of the pharyngeal muscle, causing gagging or retching. The afferent limb is formed by the glossopharyngeal nerve and the efferent limb is formed by the 10th cranial nerve, the vagus nerve, which causes the pharyngeal constriction. The next reflex we'll see is the carotid sinus reflex. The pressure on the carotid sinus slows down the heart rate. The afferent limb is formed by the glossopharyngeal nerve and the efferent limb is formed by the vagus nerve. The next reflex we'll see is the sneezing reflex. When the nasal mucosa is irritated after a sharp inhalation, the explosive inhalation occurs with the closure of the oropharyngeal isthmus by the action of the palatoglossus muscle, which diverts the air through the nasal cavity and thus expels the irritant. The afferent limb is by the ophthalmic or maxillary nerve and the efferent limb is through the vagus nerve. Next reflex we'll see is the jaw jerk. If the muscle which closes the jaw, the masseter muscle, the medial pterygoid muscle and the temporalis muscle are rapidly stretched, the jaw is reflexly closed. The afferent limb is formed by the mandibular nerve and the efferent limb is also formed by the mandibular nerve. The jaw jerk reflex is only monosynaptic reflex mediated by the cranial nerve. A small pair of nerves that are closely related to the olfactory nerve has been described as the 13th pair or O pair of cranial nerve, that is the nervi terminalis. Each nerve is a minute bundle of mainly unmyelinated nerve fibers which is attached to the cerebrum posterior to the olfactory stria close to the anterior perforated substance and the septal area. The nerve runs forward along the medial side of the corresponding olfactory tract and its branches traverse the cribriform plate of the ethmoid and are distributed to the nasal mucous membrane. But its exact function is unknown. It is thought to provide a special chemosensory pathway of olfaction and affects the secretion of the luteinizing hormone releasing factor from the hypothalamus. It also plays an important role in the smell mediated sex behavior.